First of all, a disclaimer. I am employed by a commercial entity, and although I don't think anything I'm presenting is biased, I'm going to be talking from the perspective of a commercial entity. Let me tell you a little bit about Health Dialog before I get started here. And I think most of you are familiar with Health Dialog, but we've been in the business of the work of shared decision making since 1994. We have about 650 employees. We're a subsidiary of Bupa, which is based in the UK. We provide really full service population health management services, including analytics to a wide variety of organizations, including commercial health plans, Medicare Advantage plans, managed Medicaid plans, FEP plans, and now increasingly directly to provider organizations. We are an exclusive partner with the Informed Medical Decision Foundation, and we develop many decision aids in consort with the foundation. Our mission is to empower people to make healthcare decisions that are right for them. So this is what we're all about, and we do work extensively with Dartmouth as well, have incorporated the Atlas approaches into our predictive models. We do offer products directly associated with shared decision making. We call this array of products Decision Dialog, and they include everything from identification models and approaches to thinking about who are the people who need these decisions, to doing other analytics to help think about the array of services provided along the pathway and help contextualize information for people at different stages of their care. And then we offer these decision aids and also full service 24/7 health coaching, telephonically and on-site increasingly. And the health coaches are actually trained and certified, all of them are trained and certified in shared decision-making coaching. So I'm going to talk to you a bit about what purchasers of these services or potential purchasers of these services actually want from shared decision-making. What do they care about? What are their reactions to it? I'm then going to talk through a little bit of a case study. We did a very large study with one of our commercial health plan partners, and they had some very interesting reactions to a well-structured study. And then I'll talk about the challenges of what measurement are as you expand the view of shared decision-making beyond what most of us think about as the core of it around surgery decisions. So, what do purchasers think of this? And I'm not talking about the enlightened Kaisers. I'm talking about the general public out there who we talk to. First of all, this next few slides are informed by receiving dozens of RFPs related that talk about shared decision making, and also doing about 26 structured interviews with health plan medical directors, marketing executives, and quality executives. So I'm not going to give you the numerics on this, but I'll talk about what the lessons were from those activities. So basically, we hear frequently when we're out talking about shared decision making, it's a great concept. People love it. They think it makes sense, and the enthusiasm you hear around here is heard out there in the field. But the next question is always, what is the impact of this? What difference is it going to make? So, unlike Kaiser, they are not true believers yet. What do employers want from shared decision making? Well, they want happy and productive employees. I'm simplifying this, but this is basically what we hear over and over again. And they want to appropriately spend less on healthcare. And what do health plans want? They want those same things because their customers are asking for it. But they also don't want their providers to be unhappy. They may actually even want them to be happy. I don't know. So when purchasers tell us what they want us to measure when we implement shared decision-making programs, they want to make sure that their patients are getting better experiences, are getting higher satisfaction as a result, that their basically they're costing less money is the number one message. I'll give you some quotes from some of these interviews we did. They're pretty pointed about that point. And they want more productive workers. What they also want is some assessment of whether those results, those big results, are plausible. Did enough people actually do this? Did enough people get shared decision making? Did those decisions in general seem to be better? Which I think is really where we've been spending a lot of time, is talking about what better decisions mean. And they also want to know if the utilization rates change. And I'll just give you a couple of the quotes here. The only way to get ASO groups on board and get internal traction for a project like this is with rock-solid cost savings projections. We want to be sure the process is indeed altering behaviors and ensuring the right decisions. Patients need to be satisfied with the outcomes and process. If you cannot demonstrate that you can at least do it at least as good quality, and that you do it in a way that provides an ROI, we do not need you. Quality decision-making and patient satisfaction would drive improved clinical outcomes. The financial savings should follow. Satisfied patients will be loyal to the organization, and it's cheaper to retain members you already have rather than attract new ones. So these messages of satisfaction and lower costs are paramount. Actually, the quality question is secondary, and the question of really understanding how the decision-making process changes is supportive, but not the central question for most of these unenlightened health plans. What they aren't really asking yet is, how do you do this? And what do you compare your outcomes to? I think the presentation that Dee did really gets to that point. It's very complicated to do this kind of assessment in general, but I think once you start talking about costs, the question of compared to what are huge. I'm going to talk now about a case study that we performed. It was actually a very large randomized trial of shared decision-making approaches, and this is a bit different than the provider model. This is us as a provider of services acting on behalf of a large health plan, actually disseminating proactively shared decision-making to people with specific risks. And what we did is we did claims data analysis to figure out people who we thought had high likelihood of need for back surgery or joint surgery. Then we actually surveyed them, made sure that they had pain and that they were in the process of making decisions about their care, and then we randomized them into 3 different groups. We either gave them a DVD, just mailed them a DVD, or we mailed them a DVD and then had follow-up health coaching, or we didn't do anything for them. And on the back end, we were measuring outcomes such as surgery rates, PMPM costs, and we did extensive surveying in partnership with the foundation about decision quality. So you can see the numbers are pretty large here. We've got about 10,000 people in this study, and they're split evenly between these 3 different interventions. The headline results, I realize this may be a little hard to see, the DVD and health coaching actually did result in statistically significantly lower surgery rates. And the decision aids did, in general, improve decision knowledge. And that was, both those results were statistically significant. There was no impact on some of the other measures of decision quality, like confidence, engagement with providers. There were not clear differences in the way that people, the course of treatment preferred. Those kinds of things were not different. And then overall, we had medical costs that were directionally lower, but they weren't statistically significant. When we talked to the health plan who helped sponsor this study, they were pleased with these results. They thought these were promising, and they really thought that it indicated that decision aids worked, that they improved knowledge was a really important aspect of this for them. But they thought the only way that we're really going to get into the decision quality issues was to engage better at the provider site. So this is not dissimilar to, I think, what all of us think, that we need to get the point of connection at the provider offices and not just remotely. The most interesting part of this, though, was that they didn't necessarily see the value of health coaching. And the reason they didn't is because it didn't produce a statistically significant result on cost. So I think that's, for us, was a little bit eye-opening and frankly a little troubling, particularly since the results actually looked directionally very strong. We had, these are now intent to treat groups. This is a randomized trial, so we've got people in a DVD-only group and a DVD plus coaching group, some of whom didn't view the decision aids and some of whom didn't get health coaching because our processes were not entirely effective. We had reach rates in the coaching group of about 30 or 35%. But we see here that particularly with the DVD plus coaching group versus control, we saw the facility costs on average were almost 9% lower. And yet that wasn't enough because it wasn't statistically significant for this health plan. So what are the lessons here? Well, I mean, I think we are faced with this frequently, that it's really hard to demonstrate the impact here. We had a huge randomized trial here. Still can't demonstrate this even with a pretty sizable impact on cost. And even in this case, even a buyer who's quite supportive of the notion of shared decision-making has been working with us on shared decision-making for many years, want definitive proof in their populations. This isn't idle chatter for them. They care about it making a difference to their bottom line. All right, well, I'll close up with just some other observations, which is that, you know, we really are trying to think hard about how to expand well beyond the question of surgeries. The traditional focus of, at least at Health Dialog, and I think in many instances around preference-sensitive care, around the shared decision-making on surgical decisions, has focused, that's been the typical focus of shared decision-making. But there are many important decisions that go well before the point of actual action on the surgery. So you know, as people have onset or they're in the sort of early stages of progressing in their condition, they have big decisions to make there, and there's potentially high leverage. There's also big decisions after the fact, after they've had the surgery, and actually at the point of having the surgery, it has some decisions associated with about what provider you choose. So the questions I have are, you know, what other measures do we need to worry about beyond the sort of focused decision quality around surgery decisions? And we are certainly wrestling with this aggressively right now as we expand this frame and think about shared decision-making on a continuum, thinking about things like health behaviors and the use of medications and the use of other therapies and imaging and specialty use and those kinds of things, as well as whether knowledge changes and symptoms change over time. And then on the question of providers, provider selection, recovery, complications associated with surgery, the transition and readmission issues, as well as time to return to work. Those are all sort of more, just to add more challenge to our measurement agenda here. I think we need to think hard about what happens when we expand the scope of this.